All right, welcome to this meeting of ICER on eculizumab and efgartigimod for the treatment of myasthenia gravis, effectiveness and value. This is a meeting of the New England Comparative Effectiveness Public Advisory Council, or CEPAC. I'm Dr. Steve Pearson, the president of ICER. Let me hand it over to the chair of the New England CEPAC, Dr. Jason Wasfy, to bring the meeting to order and to begin us with some introductions. Jason?
Hi, good morning, everyone. My name is Dr. Jason Wasfy. I'm the chair of New England CEPAC. I'm an associate professor of medicine at Harvard Medical School, and I direct our health outcomes research program at the Massachusetts General Hospital. So with that, I'd like to call the meeting to order, and I will call on individual members of the New England CEPAC to introduce themselves and declare any potential conflict of interest. So at the beginning of every New England CEPAC meeting, we want to ensure that all speakers disclose any financial relationships with industry. Every member of our New England CEPAC panel who is present today has met the ICER conflict of interest policy. Would each New England CEPAC member introduce themselves, maybe briefly about your work, and then note whether you have any updates to the prior declarations of conflicts of interest.
Jason, why don't you run the list as you've got it? You don't have to read it out loud. That way we can probably go through the list more quickly.
Okay, I'm sorry, I don't have the, I can't see it on the screen, and
Maggie, can you provide Jason with a list of the New England CEPAC members who are at the meeting today so he can run the list?
Jason is actually,
yeah, I'm sorry. I have a list now. I just want to. What I'll do is I'll call out people in order. It won't be necessarily the order on the screen. Let's start with Dr. Austin Fracht.
Hi, I am a health economist. I do research at the VA Boston Healthcare System, the Boston University School of Public Health, and the Harvard T.H. Chan School of Public Health. I'm also editor-in-chief of the Journal Health Services Research. I have no additional conflicts of interest to declare.
Thank you so much. Next will be Megan Golden.
Hi, I am co-founder and CEO of Mission Cure, a nonprofit that is developing effective therapies and improving care for pancreatitis. And I have no additional conflicts. Thanks.
And then next will be Professor Martha Gold.
Good morning. I'm Dr. Martha Gold. I'm a public health physician. I'm professor emerita at the CUNY School of Medicine. My work relevant to this has really been both in public health and in measurement of outcomes for health interventions. No conflicts.
Thank you so much. Next is Rebecca Kirsch.
Good morning. I'm with the National Patient Advocate Foundation, and our mission is to support the needs of patients and families in limited resource populations. My background is in health policy and practice change. No conflicts.
Thank you so much. Next is Dr. Steve Kogut.
Good morning, everybody. I'm a professor at the College of Pharmacy at the University of Rhode Island. I'm also a member of Rhode Island's Drug Utilization Review Program for Medicaid, and I serve as Director of Tracking and Evaluation for our state's federally funded Clinical and Translational Research Program. I have no updates to my conflict of interest statement to provide.
Thank you so much. Next is Dr. Don Kreis.
Good morning, everybody. I'm Don Kreis. I'm a lawyer who serves as New Hampshire's consumer advocate, which means I advocate on behalf of residential ratepayers in the public utility space. But I'm really here today in my capacity as a patient advocate, having had the pleasure of raising a daughter who has cystic fibrosis and is now a thriving college student.
Thank you so much. And next is Dr. Tara Lavelle.
hi everyone. I'm Tara Lavelle. I'm an assistant professor at Tufts Medical Center, and I'm a health economist by training. I have no updates to my conflict of interest.
Thank you so much. Next is Dr. Greg Lowe.
Good morning. I'm a pharmacist and pharmacoepidemiologist. I'm the director of the Mass General Physicians Organization's pharmacy program. I also sit on the Massachusetts Drug Utilization Review Board for Medicaid, and no updates to my conflicts.
Thank you so much. And next is Dr. Aaron Mitchell.
My name is Aaron Mitchell. I'm a medical oncologist and health services researcher at Memorial Sloan Kettering Cancer Center in New York. I have no conflicts or any updates to them.
Thank you so much. And so last but not least is Dr. Brian O'Sullivan.
Hi, I'm Brian O'Sullivan. I'm a pediatric pulmonologist and professor of pediatrics at Dartmouth Hitchcock Medical Center and Geisel School of Medicine, and clinical director of the Cystic Fibrosis Center here.
Okay, wonderful. Thank you so much. And then I'd also like to call on several patient and clinical experts to maybe introduce yourselves to the group, and please remember to declare any potential conflicts of interest according to the ICER policy. So first on that list, we have Adrija Udrupute.
Good morning. Yes, my name is Adrija Butte, and I am a patient expert here. I'm a practicing attorney in Louisiana, and I have no conflicts.
Thank you so much, and thank you for joining us this morning. Next is Marcia Lorimer.
Good morning. I'm Marcia Lorimer, and I'm an ex-board chair from the Myasthenia Gravis Foundation. In my real life, I'm retired assistant professor emerita from Duke University, and I have no conflicts.
Thank you so much. And next is Dr. Pushpa Naraswamy.
Hi, good morning. I'm a neuromuscular neurologist at Beth Israel Deaconess Medical Center, affiliated with Harvard Medical School. And I have consulted for Alexion, Argenx, and UCB previously several years ago for Momenta, which is now Janssen. I've also received research funding from Janssen, Momenta, and UCB and Alexion.
Thank you for joining us this morning. And last is Dr. Gordon Smith.
Thank you. I'm Gordon Smith. I'm a neuromuscular neurologist. I am a professor of neurology and chair of the department at Virginia Commonwealth University. I've done consulting with both Alexion and Argenx, and either chair or members of or member of DSMBs for IDOS and Lexicon.
Thank you so much all. Thank you to all of you for joining us. I'm sure you're going to enrich the conversation this morning. And I just sort of in the way of ending, I just would request that other speakers later in the day, including people who are in the policy roundtable and individuals making public comments before they speak, should announce any financial relationships with industry or other potential influences on judgments before they speak. We will also present this information publicly on slides. And so with that, I'd like to turn it over to Dr. Steve Pearson, who is the president of the Institute of Clinical and Economic Review.
Thank you, Jason, and thank you to all of those who are watching, and thank you very much, as you said, to our patient experts and clinical experts who are joining us, and to the entire New England CEPAC. We start off our meeting by grounding it in the question of why we are here today. And we like to take a quote, a statement from a person with the condition. So let me read this out for you. A diagnosis with myasthenia gravis is like a full-time job. The length of time it takes to find a treatment that's going to possibly improve your condition while keeping the distraction in your life to a minimum, all while knowing there is currently no cure, is a heavy load to bear. Not to mention the impact of living with a chronic rare disease such as myasthenia gravis, and the impact it has on your relationships, your family, your career, and just about everything else you can think of. These are factors and burdens that cannot be dismissed and must be valued when looking at the overall picture. This came from Justin, and this slide also allows me the opportunity to note with our condolences the passing yesterday of the board chair of the Myasthenia Gravis Foundation, Nancy Law. We learned about that this morning, and the team spoke with Nancy early in the process of this report. And she herself is a person who has myasthenia gravis, had myasthenia gravis. And I just wanted to note that the entire team wished to express their thanks for her engagement, for the insights that she provided them early on, and again, our condolences to her family and to all of her colleagues at the MGFA. So we're also here today, not only because of the patient's needs and the impact of this kind of condition on their health and on their broader lives and relationships, because we are dealing with some exciting potential new opportunities for treatment, some which have recently entered practice and some which are on the cusp of doing so. And it's helpful to reflect, we think, just what happens the day these treatments are approved by the FDA. One thing that happens is, and you can tell based on the statement from Justin, the patient, there is a recognizable sense of achievement, of elation, and of celebration that all the work, all the risk, all the investment, all the time and effort of patients and clinical researchers and companies have culminated in the opportunity to have something better to do for patients and their families. And so that's a very, very exciting aspect of what happens when they're approved by the FDA. Also, when they're approved by the FDA, although it starts beforehand and starts to trickle into the days and weeks afterwards, but what often happens that first day is the drug receives a price, and insurance companies start to create more formal approaches to the coverage policy that will govern how patients will receive insurance coverage. Meanwhile, patients and doctors themselves in the office are now, if you will, offered this opportunity, but there's still a lot of uncertainty, both about the effectiveness, the pricing, the cost, and the coverage. So patients often can have difficulty accessing drugs, especially in this early phase when these issues are still on the table and they're wrestling with them. Now, in addition to thinking about the patients with myasthenia gravis, another reason we're here today is because we feel it's important to note that nothing happens in a vacuum and that things are happening to others in the healthcare system when we welcome new treatments into the use of doctors and patients. And just briefly, I want to share three stories to put a name, if you will, to some of these ideas. And it's related to the impact of rising healthcare costs, because frequently when we do welcome a new treatment, it's not going to end up ultimately reducing the costs of care overall. It's going to add to them. And when that happens, it has a broader effect, a ripple effect. So Mr. Leonard Edlow is a pharmacist himself in Virginia, and he has spent a large part of his career bearing witness to the struggles that he sees in his patients and in his community wrestling with increasing healthcare costs. And in stories written up in the press, he described how difficult the trade-offs were that many of the families that he worked with were trying to make between affording their rent and other necessities and the costs that they were asked to bear for new treatments. The Whitman family in Alaska was written up in a separate article as an example of what happens to patients and families who are struggling with affording their entire health insurance package. A self-employed family, they had to give up insurance they felt several years ago when the premiums rose too high. And in the years afterwards, they had expressed a lot of concern about the effects on their children in particular, who'd suffered a concussion, other injuries that they just felt without insurance, they couldn't go to the ER. And so they were living with a lot of stress, anxiety, and some guilt even they expressed around the fact that they felt they could not afford health insurance and the negative effects this was having on all of them. And the McCoo family in Minnesota were written up recently. They expressed they've been working with insurance companies and others because they are in deep medical debt due to the long-time care of their daughter, shown here in the picture with her hat on. And they're a good example of over 20 million American families that are in medical debt receivership today. And the struggles that they go through and the stress of trying to emerge from that debt, the stress of falling back into it. This is a sad part of our healthcare system, obviously, but it's just part of what we have to remember when we think more broadly about why we're here today, to help manage not only the benefits that can come from new treatments, but the broader effects and the decisions that have to go into how we afford them in a way that can address many of the other problems that come with rising healthcare costs. So in a very simplistic way, Today, we're going to have our eyes focused, as they should be in many ways, squarely on families with people living with myasthenia gravis. This needs to be the ultimate focus of clinicians of our work, is to help improve their lives. But it doesn't mean that we can forget about the families with other health conditions, everybody trying to afford health insurance overall, and the need to have a structure for bringing treatments in and through into care that is affordable and at prices that align with the value to patients, so that we can all be part of this thriving community. So that's why we're here today, and you've been introduced to the members of the New England Comparative Effectiveness Public Advisory Council, an independent group of folks that we convene. Let me tell you a few words about ICER, which is the convening host and the academic kind of secretariat to this work. First, our sources of funding, which we keep updated on our website. This is our overall revenue. As you can see, about 68% come from nonprofit foundations. The largest among that set include the Laura and John Arnold Foundation and the California Healthcare Foundation. We receive about 21% of our funding directly from life science manufacturers and health plans and provider groups, but that is kept separate to support our ICER Policy Summit and activities not related to the reports and the meetings that we hold on new technologies. We have about 10% from government contract funding and 1% from individual donations. So the report itself that serves as the kind of backbone to the discussion today was developed over about an 8-month period. And it starts with what we call scoping. That's when we reach out for early guidance from patient groups, from clinical experts, manufacturers, and other stakeholders. And patients in particular help ground us in a broader understanding of what matters to them, what is the diversity of their experience with this condition, things that obviously even clinicians may think they know, but don't. And we come in eyes wide open to try to make sure that we get their orientation before we start to really look at the evidence and think about what value means from their perspective. Then we do an internal work of looking at the available evidence, not just published evidence, but work that we might even do with patient groups to generate new information from patients, work with manufacturers to get information that might not be in the public domain. We use that to look at the clinical effectiveness. We also use it when we work with outside academic partners to develop cost effectiveness models. In this case, we work with researchers at the University of Illinois at Chicago, who you'll see later. Our reports go through cycles of public comment and revision, and we were also fortunate to have expert reviewers for this particular report, Dr. Aaron Lewis, Samantha Masterson, Pushpa, as you've met, Dr. Narayana Swamy, and Dr. Smith all had a chance to read the review before it was finalized and to give expert commentary. So how is the report itself structured in a way to support the kinds of discussion that we think is going to be helpful to meet that goal of keeping our eye on the target of the patient and family while having the broader view also in mind? So for us, that it connects to our view of value and a value assessment framework that ultimately leads to a consideration around the long-term value for money of new treatments. And this is a complex kind of set of issues that have to be thought of together. And it does start at the base, if you will, with whether treatments can sometimes help us live a longer life, depending on the condition. It may also, or instead of that, help us return to higher function or slow down a kind of decline in function. It may have fewer side effects than other equally effective treatments. We look at the total costs overall, not just the cost of the drug, the treatment itself, but the broader effect, again, on doctor visits, on hospital stays, on other tests, to try to make sure that we're looking at value as comprehensively as we can. And that includes at the top elements that are sometimes not even that easy to quantify, but we want to talk about the benefits beyond the health that we can measure. And you'll hear conversation and votes on some of these potential other benefits that can accrue to patients and families and society from new treatments. And we'll also talk about these kinds of overarching social and ethical priorities around how we allocate our resources. Do we want to give special priority to treatments for conditions that have special types of severity or length of burden on patients? We'll talk about that, and that will also be part of the vote. that the New England CEPAC will take. So this is the backdrop to the conversation that we're going to start now. And again, we're very glad to welcome the participation of clinical experts and representatives from the patient community. They are with us from the very beginning. As we start with, first a quick look at the agenda. Sorry, we'll go from now till 4 p.m. There will be presentation of the information followed by formal public comments and discussion. Lunch will be from about 12:05 to 12:50. Then we'll come back for the vote. And after a short break, we'll tackle some really important policy issues in the roundtable, where we will have one of the manufacturers available, clinical experts, again, patients and payers, to help us really round out our discussion on how we'll translate the evidence and what we can know about these treatments and their pricing today into the best possible future for patients in the health system. So we'll be done by 4 p.m. following some final reflections from the individual members of the New England CEPAC themselves. So with that, let me now hand it back to Dr. Jeff Tice, who's a professor of medicine at the University of California, San Francisco, and was the lead evidence author on this report. And I will remind the New England CEPAC that they have at their disposal clinical experts, patient experts, and they should feel free to dive in as Dr. Tice presents the information. And so let's kick it off. Jeff.
Great, thanks, Steve, and good morning, everyone. Next slide, please. So I just want to acknowledge my collaborators at ICER, Dimitri Nikitin and Avery McKenna, who did much of the heavy lifting in pulling the evidence together for this report. And none of us have any conflicts of interest to report. Next slide, please. So by way of background, myasthenia gravis is an autoimmune disease that affects the neuromuscular junction. So it affects muscle function. The key feature, the way it's described, is fatigable weakness. It often starts in the head with eyelid weakness, swallowing difficulties, but can progress to more generalized disease involving muscles throughout the body, and that's known as generalized myasthenia gravis. By fatigable weakness, what that means is initially, for instance, somebody can blink, but as they blink repeatedly, they no longer can lift the eyes. You have eyelid drooping. And the same thing with repeated use of muscles, they become weaker and weaker. It is a chronic disease, so we don't have any cures for it, but it's not progressive after the first, say, 2 years. Over the first 2 years, you may present with initially eyelid drooping and swallowing issues, but it can generalize. So it does not everybody evolves to generalized myasthenia gravis. It's characterized by a number of autoantibodies. The most common are antibodies to the acetylcholine receptor. And this is the classic disease that those of us who are physicians learned about in medical school. About 85% of patients with myasthenia gravis have antibodies to the acetylcholine receptor. There are several others that have been identified. One against muscle-specific kinase, or MuSK, affects about 6% of patients. Another against low-density lipoprotein receptor-related protein 4 affects about 2%. And then there's a small percentage of patients who clinically have myasthenia gravis, but we've not identified any autoantibodies. It's a relatively uncommon disease. The prevalence is between 14 and 20 per 100,000 people in the United States. Next slide, please. So we heard a lot from patients initially about the long and frustrating path to diagnosis. The symptoms can be subtle, and myasthenia gravis is uncommon, so most physicians don't care for anyone with myasthenia gravis and may not recognize the disease when it first presents. It also is challenging because for no reason a patient suddenly can have worsening of their disease, a flare, and that uncertainty carries a certain mental health burden. Also, patients are often tired, fatigued, those who live with this illness, and this impacts their school, their work, and their personal relationships. We also heard that the side effects can be worse than the disease. One of the early treatments is corticosteroids to quiet down the immune system, decrease the autoantibodies, and as we all are aware, initially corticosteroids can raise blood glucose levels. If somebody has diabetes, that gets worse. People have a significant weight gain, acne, and then long-term, there are issues with many chronic illnesses such as osteoporosis and hypertension and other things. Many of the therapies used to decrease their reliance on corticosteroids require IV infusions, and this often is challenging. It requires travel to an infusion center. This can impact their jobs, and we also heard that patients really like the ability to perform home infusions, but sometimes there are insurance barriers to receiving their IV infusions in the home. Next slide, please. Other insights from patients, the COVID pandemic has been particularly burdensome for patients. They are afraid of going to medical centers for their regular provider visits and infusions because they don't want to be exposed to COVID. They're at higher risk for severe COVID disease, both because of immunosuppression from the medicines used to control their disease, as well as a respiratory compromise in many people. And finally, because of the immunosuppressive medicines, they often have a poor immune response to vaccination, so they don't get as much benefit from the available vaccines to prevent COVID disease. There are a number of race, ethnicity, and gender disparities. The disease presents earlier in life for women compared with men, and it's particularly true for Black or African American women. They present earlier than any other group. For women, there's an impact of delayed or lost childbearing due to predominantly from the risks of the medications. And many of the medications are expensive, leading to high out-of-pocket costs in addition to the insurance costs. Next slide, please. So the standard approach to therapy is initially protistigmine, which is an acetylcholine, prevents the breakdown of acetylcholine, and thus leads to greater stimulation of the receptor and better muscle response. As that is no longer effective, corticosteroids are often the next line therapy. And then to decrease the dependence on corticosteroids, a number of immunosuppressive drugs are used. The two most common are azathioprine and mycophenolate mofetil, but there are many others that are used, including rituximab and IVIG as maintenance therapy, not just for an acute crisis. A myasthenia gravis crisis is when a patient begins to have challenges breathing because of muscle weakness, and often patients end up on ventilators for respiratory support. IVIG and plasma exchange are used to manage these crises. And looking over time, the newer therapies, better immunosuppressive drugs have reduced mortality, but not remission. So we don't see many patients going into long-term remission. They remain dependent on immunosuppressive drugs to control their symptoms. Next slide, please. So scope overview, we're focusing today on adults with generalized myasthenia gravis who have failed or are intolerant of standard therapy. The two interventions of focus are eculizumab and efgartigimod, and the comparators are standard of care or other interventions. These drugs are added to those, they don't replace them. And in the scoping phase, we heard of the importance of looking at rituximab and maintenance IVIG as comparators, though there are limited data there, and we'll briefly touch on that today. The primary outcomes that were important for the model, and we heard from patients and clinician experts, are the quantitative myasthenia gravis scale, or QMG. This is physician assessed and has a number of objective measures of strength and breathing incorporated into it. And then a patient-reported measure, the myasthenia gravis activities of daily living scale, or MG-ADL. Next slide, please. The main interventions I mentioned, eculizumab is a monoclonal antibody inhibiting complement 5 cleavage. This is an IV infusion given every 2 weeks, and it was approved for acetylcholine receptor antibody positive generalized myasthenia gravis in October of 2017. Efgartigimod is an immunoglobulin G1 Fc fragment antibody that leads to decreases in IgG levels in the body. It's given by IV infusion weekly for 4 weeks, and then as needed in additional cycles of 4-week infusions. We'll say the clinical trial protocol required 4 weeks of weekly infusions and then 4 weeks off of therapy. It's unclear if the real-world dosing will reflect the clinical trial protocol. An FDA decision about this therapy is expected in December of this year. Next slide, please. So I talked about the 2 outcome scales. I just wanted to give you the minimum clinically important difference for these therapies. For the QMG, it's 2 points for mild to moderate disease. That is patients with a QMG less than 16. So higher on both of these scales is worse disease. For patients with a QMG above 16, equal to or above 16, a 3-point change is considered a clinically important difference. For the MG-ADL, the minimum clinically important difference is 2 points on that scale. And again, higher is worse. So we hope to see a reduction in these scores with effective therapy. Next slide, please. Now we'll turn to the clinical evidence. There are 2 key clinical trials for eculizumab. It's the REGAIN trial. They randomized patients who were positive for antibodies to the acetylcholine receptor and refractory to treatment. And they defined refractory as at least 2 prior immunosuppressive therapies or 1 prior therapy plus maintenance IVIG over the past year, given at least 4 times. And despite these therapies, that they had an MG-ADL score of 6 or higher. Efgartigimod, it was studied in the pivotal trials called the ADAPT trial. They included both patients who were positive or negative for the acetylcholine receptor antibody, and they required patients to have an MG-ADL score of at least 5 and be on a stable dose of at least 1 treatment for generalized myasthenia gravis. I will say, despite the fact that they enrolled both antibody positive and negative patients, their primary outcome was in antibody positive patients. Next slide, please. So here are the primary results at 4 and 8 weeks from the trials. For eculizumab, the results were fairly similar, decrease of a little over 3 points at 4 and 8 weeks, whereas the placebo group had about a 1.5 point reduction. For the QMG scores, they decreased by 3.3 and then 4 points at 4 and 8 weeks respectively, with about a decrease in 1.5 points in the placebo group. In the ADAPT trial for efgartigimod, there was a slightly greater decrease in the MG-ADL at 4 weeks at minus 4.6 points. But at 8 weeks, that had decreased to only minus 2.2. And you see the placebo group had a minus 1.8 change in the MG-ADL score. And again, this reflects the dosing of the drug. They had 4 sequential weeks on therapy and then 4 weeks off therapy. And they were redosed when their MG-ADL score decreased to less than 2 points. So they could go more than 4 weeks without therapy. It was individualized based on their response, but they received no doses during weeks 5 through 8. And that's reflected in the decrease in the MG-ADL score. And if you look at the QMG, you see a similar pattern, slightly greater or a reduction in the QMG at 4 weeks. Compared to eculizumab, and much better than placebo, but much of that benefit is lost by 8 weeks. We'll say 2 other things. The primary outcome for the trials were different. They used a least squares mean regression analysis for regain, an unusual kind of worst rank ANCOVA score. They ranked all of the patients from 1 to 125 in terms of how they did and compared them using an ANCOVA score. It was 56.6 versus 68.3, and the p-value was not significant. So for the primary outcome for eculizumab, it was not statistically significant, though close, but the other scores that I presented up above were all significantly different from placebo. For the ADAPT trial, their primary outcome was a reduction in the MG-ADL score of at least 2 points, so a clinically important difference that was maintained for at least 4 consecutive weeks. So again, a sort of spin on just our normal measure at, say, 8 weeks, what the difference was. They had to maintain at least a 2-point improvement for 4 consecutive weeks, and this happened in 68% of the patients who received efgartigimod versus 30% in the placebo group, highly statistically significant. Next slide, please. For rituximab, there's no published data. There's one important trial called the BEAT-MG trial, which should be published soon, but the primary results were available, and the primary outcome there was a reduction in prednisone dose of at least 75%. This was achieved by 60% of patients in the rituximab group and 56% of patients in the placebo group. These results come from clinicaltrials.gov and abstract data, but there was no p-value available. For IVIG, similarly, the one good randomized trial, there was no difference in the reduction in prednisone dose, which was the primary outcome, but there were significant reductions in the QMG, a reduction of 4.6 points versus 2.7 points in the placebo group. Again, neither of these trials have been published. Next slide, please. So turning now, those results I should have said were all in acetylcholine receptor antibody positive patients. In negative patients, the only data are in the subgroup of the ADAPT trial. There were only 38 patients, 19 received efgartigimod, 19 received placebo, and they describe these analyses as exploratory analyses in the published paper. So no p-values or confidence intervals were reported. For the MG-ADL response in the first cycle, 68% of patients in the efgartigimod group responded versus 63% in the placebo group. And for QMG, it was 53% versus 37%. Again, no other statistical analyses were presented. Next slide, please. So harms, there are fewer SAEs versus placebo for both new therapies, likely reflecting improvements in their myasthenia gravis. However, there were more discontinuations due to significant adverse events for eculizumab, 6% versus 0% in the placebo group, but not for efgartigimod. It was 3% in both the active treatment arm and the placebo group. And there is a black box warning for eculizumab. It's known that there's a risk for a meningococcal infection, and so patients must be vaccinated for meningococcus prior to initiating therapy with eculizumab. Next slide, please. There are a number of controversies and uncertainties. It's unclear when or if to stop either one of these drugs, whether they can be used to initially get patients under control, lower their corticosteroid doses, and then weaned off and maintained on other immunosuppressive doses, or just maintained on these therapies. There's also insufficient data on important patient subgroups, the different antibody subgroups. I described the antibody negative patients for efgartigimod, clearly very sparse data. And also, as I noted earlier, there's some disparities with Black and African American populations, particularly females, and there's really limited data in those subgroups to date. The appropriate dosing regimen for efgartigimod is not clear. We don't know for sure what will happen, but it would be surprising if patients and clinicians allowed the disease to worsen close to baseline before redosing. So it may be that patients will receive therapy more frequently than at a minimum of 4 weeks on, 4 weeks off. And if that's the case, there may be additional harms, adverse events that weren't seen in the trial because of the way therapy was delivered in the clinical trial. There's a very limited comparative effectiveness data for maintenance IVIG or rituximab, despite their widespread use in clinical practice. Next slide, please. So potential other benefits and contextual considerations. Myasthenia gravis is a serious lifelong illness with 60 to 80% of patients not achieving their treatment goals, so minimal symptoms with their current therapies. Myasthenia gravis affects women early in their working lives, which leads to reduced work hours, slow career progression, and often early retirement. Hopefully we'll hear a little bit more about this from our patients today. This is particularly true for Black and African American women. Caregivers are often needed to help with travel, feeding, and communication. As I noted earlier, patients with myasthenia gravis are particularly vulnerable during the COVID-19 pandemic. Next slide, please. Public comments received. Prioritize the patient voice. We agree. We have a section devoted to that. We have 2 patients here today. Hopefully, we can hear from them, and their perspective should drive our understanding of the value of these new therapies. We highlighted death due to myasthenia gravis while on eculizumab. The company pointed out that this occurred after stopping eculizumab, so it should not be considered an adverse event. However, the patient was receiving eculizumab when the myasthenia gravis crisis occurred. They then stopped, but they died from that crisis. So we think it's important to highlight that that death occurred despite use of eculizumab. We heard a lot of feedback about using real-world data. Unfortunately, there are no published comparative analyses, even for eculizumab, which has been available for 3 to 4 years in clinical practice. And finally, we also heard that rituximab should be limited to patients who are positive for the MuSK antibody. That's certainly out there in the clinical lore, but the MGFA guidelines did not limit rituximab to MuSK positive patients, nor was this part of the inclusion criteria for the BEAT-MG trial, the randomized trial of rituximab that hopefully we'll get more data from in the upcoming months. Next slide, please. So in summary, eculizumab didn't meet its primary endpoint, but it had consistent clinically important improvements in the MG-ADL and QMG scores at 26 weeks. I presented the 4 and 8 week data. At about 8 weeks, the results plateaued, and in long-term extension studies, these were maintained through 130 weeks. So reassuring that these benefits can continue for 2 years or so. There is the black box warning for a meningococcal infection. For efgartigimod, we saw significant improvements after the first cycle, so at 4 weeks. They declined by 8 weeks, and then in follow-up, they would go up and down with subsequent dosing of efgartigimod. No important harms were identified, but again, I want to highlight the uncertainty about real-world dosing, whether clinicians and patients will tolerate this waxing and waning symptoms before reinitiating therapy. And finally, really, there's insufficient data on rituximab and IVIG, despite their clinical use, and insufficient data comparing eculizumab versus efgartigimod. We did attempt to do a network meta-analysis, but we only had data at 4 weeks, which really isn't sufficient for adequately comparing the 2 therapies. Next slide, please. So based on that, for eculizumab, we gave it an ICER evidence rating of B+. This is the second highest rating that we can give. And this is a moderate certainty of a small to substantial net health benefit. For efgartigimod versus placebo, we gave it a C++. This is moderate certainty of comparable, small, or substantial net health benefit. The increased uncertainty here was because of the uncertainties about the dosing. And with increased dosing, potential adverse events that maybe weren't seen with a longer spacing of the therapy. For eculizumab versus efgartigimod, we gave it an I rating, insufficient evidence. Similarly for the drugs versus rituximab and IVIG, really inadequate evidence to judge the net health benefits of one therapy versus the other. Next slide, please. And finally, for antibody negative patients, the only evidence is a small subgroup of the ADAPT trial where they did exploratory analyses that suggest potential benefits, at least with QMG, though the benefits versus placebo for the MG-ADL were quite small and likely not significant. So again, we gave this an I rating, insufficient evidence for the net health benefits of efgartigimod versus placebo in antibody negative patients. Next slide, please. With that, I'll take questions.
Thank you so much, Dr. Tyson, and for the great presentation. Also, thank you and congrats to you and the whole ICER research team. We have about 14 minutes, and we normally would use this time for CEPAC questions, and I want to make sure to have a good chunk of that time for CEPAC questions. But I guess could I just first check if any of the patient experts want to make brief comments on the presentation? Ms. Lorimer, I think you're trying to talk, but I think you're on mute.
You're right. Sorry.
Thank you.
That won't be the first time today when people need to be unmuted, I'm sure. But I've been a patient for a very long time. I was diagnosed at age 10, and that was 65 years ago. So I'm really excited that we have the possibility of having targeted treatments for myasthenia. All my life, basically, we've taken other drugs that were adapted to myasthenia. And I think the possibility of having a targeted treatment is going to mean improved health for a lot of people.
It's so helpful to have your perspective, and thank you for joining us. Anyone else before I turn questions to the CEPAC? Okay, hearing none, maybe I guess I'll just start off with a question for Dr. Tice, and then I can see at least one other hand raised. I guess I'd just like to, I know you addressed this as a presentation, to probe a little bit about the REGAIN trial and the statistical methods. So obviously, whenever we see a randomized trial and the primary endpoint is missed, but then it's sort of positive on secondary endpoints, you at least have to ask questions about it. So my understanding of the worst rank and COVA, sort of a non-parametric method, sort of what they're worried about essentially is missing data. So they're worried about people falling out of the trial. Basically, if someone's myasthenia gets a lot worse, they fall out, are censored. So that's obviously a bad clinical outcome. So they kind of preemptively put in these statistical methods. So I mean, I guess my read on that is I would congratulate the trialists. I mean, I think it's an appropriate, conservative, cautious way to do the analysis. But it then sounds like a few of the patients dropped out for reasons other than myasthenia. So my read on this, and I just would love your thoughts, is that this is a very conservative, cautious statistical approach, and then the p-value was almost positive at a 0.05 threshold and directionally concordant with the secondary outcome. So my thought was that this shouldn't bother us too much, but I would love your whether you agree with that or not.
Yeah, I mean, I wanted to highlight the fact that it's a primary outcome for just the reason that you said. Normally, we focus on that, but you know, as I pointed out, 6% of patients in the active treatment arm dropped out, and that meant that they were considered complete failures. So, and that did influence the analysis, this very conservative approach, and certainly the FDA interpreted it the way you did. They approved the therapy despite the fact that the primary outcome was not met, and so they felt like maybe it was too conservative an analysis. And given the strong concordant, I didn't present all. There are two other standard measures of outcomes in myasthenia gravis that are available in the supplement. But again, all four measures were consistently in favor of eculizumab and had clinically important differences compared to the placebo group. So I think it was on the basis of really a consistent picture outside of this rather unusual statistical approach that led the FDA to give approval to the therapy.
Wonderful, thank you so much. So I see hands up from Mr. Kreis and Ms. Golden. Maybe let me try to get through those two, and then I actually see Professor Gold now. So, and then hopefully even have comments for the clinical experts. I'm not sure we'll have all the time. So maybe Don, do you want to go ahead?
Sure, thank you. Good morning, Dr. Tice. Thank you for your extremely lucid presentation. This question will hopefully sound a lot like what in my line of work is known as friendly cross-examination. With respect to the primary outcome measure that the ICER analysis relies upon, you used QMG, and I noticed that the Myasthenia Gravis Foundation said, well, wait a minute, the ADL metric or measure is the one that clinicians tend to use, and your response was, we considered doing that, but it's potentially unreliable for estimating utility, you said, due to significant floor and ceiling effects. So I was wondering if you could hum me a few more bars of why you rejected the ADL measure as your primary outcome measure in favor of the QMG.
Yeah, well, that's really for the modeling. So that was driving the model, and they're highly correlated. I might, I don't know, Dan, do you want to, because I reported both, and certainly the MG-ADL was the primary outcome in the trials. And I tried to highlight that here, and certainly that reflects the patient experience. But for the model to appropriately capture the benefits of therapy across a wide range of patient experiences, the QMG has less of those floor and ceiling effects. And I don't know, Dan, do you want to say anything else?
Yeah, I mean, I can describe a little bit what those floor and ceiling effects are. That patients who have very poor scores are likely to get clumped together, and it's more difficult to distinguish differences at the high ends and at the low ends of the scales. So patients who are high functioning, compared with other patients who are high functioning, there's less of a difference in the MG-ADL score than the QMG score, which is better able to distinguish between those. We really wanted to use the patient-centric ADL measure, but those issues with how they're measured and how they translate to utilities were potentially problematic. And that's why we chose to use the QMG. The other reason for using the QMG is that IVIG and Rituximab, those trials did not evaluate MG-ADL. And so we were able to create more equal comparisons with these other treatments, even though those were secondary analyses.
Thank you, that was super helpful.
Thank you so much. And maybe I'll call on Ms. Golden.
Yes, thank you for a great presentation. I actually had that same question about the differences between the two measures, but kind of a little bit more bigger picture. I'm trying to sort out what the impact of these treatments is on patients' lives. And I was really struck by your statement that 60 to 80% of patients do not achieve the goals of minimum manifestations. And so I'm wondering if we have any information on how that changes with these treatments. And then second question was the reason for the C++ rating for the efgartigimod, was that because of the drop off after 4 weeks? And how does that relate to your comment that you're not sure about what the real world adherence or implementation will be? Like if they decide to continue it, do we think that the impact will actually be higher?
Yeah, I mean, well, I think we don't really know. I mean, there's just that uncertainty. I think it's not out there in the real world yet, which was also adds to the uncertainty. Eculizumab, we actually have years of clinical experience, and we have published long-term data, which gives me a little more confidence in the estimates. But I think the biggest uncertainty is whether really patients and clinicians will wait 4 weeks after a dose to reinitiate a cycle. Some patients do fine, and in the clinical trial, some people, it wasn't until 5 weeks, 6 weeks, 8 weeks after the cycle that they initiated the next cycle. So that some patients had much longer benefit from the therapy, but some had shorter. And we just felt like it was likely that there may be more frequent dosing, and we don't really know what the impact will be. I mean, we know through 26 weeks, the difference between placebo waxed and waned. It got bigger and smaller throughout the course of the 26 weeks in the published data. And it seems like patients and clinicians would want a more stable benefit. And this reflected the protocol. They weren't redosed until they dropped to close to where they started. And that was, perhaps we can hear more from the company about why they took that approach, but I think it was a way to individualize, thinking some patients can wait longer for redosing, but we just don't know. So that uncertainty was what really played into this. And I will have to look at the data. They did report minimal manifestations in these trials. I don't have the figures at the top of my head, but they're in the supplement, and I'll pull them and make sure I address that later this morning.
Thank you so much. And I guess just given the topic, if I could briefly ask the clinical experts for comments about the dosing regimen, just given the topic just now. And then Dr. Gold, I promise we'll circle back to you for your question.
I'm happy to take it, and Gordon, maybe you can add comments, or you can go first. Either is fine.
Go ahead.
So I think for efgartigimod, first of all, thank you for having us here. It's been great to be part of this project from the outset. And the review is an excellent review, and I look forward to hearing the cost effectiveness discussion. In terms of efgartigimod, I think the rationale behind selecting a variable dose was because of this mechanism of action. So the mechanism of action is somewhat similar to that of intravenous immunoglobulin. And in clinical practice, intravenous immunoglobulin is used in varying cycles. So patients are maybe for a few cycles given a course every 4 weeks or so, every month or so. But then depending on clinical response, we tend to push it forward. And in clinical practice, when we use IVIG for any condition, we don't let patients get to the point of getting worse. We sort of like to catch them just before they get worse and keep a sustained response. And that's how, and that gradually varies as the disease gets better and better, that the frequency can reduce. So the intervals between two courses can increase very gradually until we get them to maybe once every 3 months or once every 4 months, and then say, okay, let's take a break from it, depending on the disease. We may not do that in myasthenia gravis because most patients tend to require some medication or other long-term. So I think because the mechanism of action of efgart is similar to that, not quite the same, but similar to that of IVIG, that was why this sort of, the trial was designed to mimic how it may be used in the real world. And so I think the rationale is good. How it's going to, and then I do have, I'm not sure, Dr. Tice, I don't think you presented this, but in terms of duration of response, in people who responded during the first cycle, so the first 4 infusions of, they got in weekly infusions, as Dr. Tice mentioned, for 1 every week for 4 weeks, and then they were monitored for 8 weeks. So that was sort of the first cycle. And in patients who respond, so we heard the definition of MGADL responders. In the first, almost 35% of patients, 34% of patients, so 15 out of 44 patients did not need another cycle for another 12 weeks. So they went for 12 weeks without actually getting worse in the trial. And another 22%, about a fifth of the patients, went for anywhere between 8 and 12 weeks. So it was quite variable. So I think that's actually exciting for clinical practice. It helps us to tailor therapies, as someone mentioned. It also helps to reduce the costs. So I think, and that is one area where we don't quite know the cost, because the cost is going to vary quite a bit between individual patients, I think. So I don't know if that answers the question. If I may, do I have a minute to touch on the eculizumab, the REGAIN primary outcome analysis? Just
Sure, maybe just a minute, and then I'll get to Dr. Gold. So thank you.
Okay, so I just wanted to sort of clarify, in terms of the worst rank ANCOVA, 7 patients dropped out of the trial, and all 7 of them were ranked worst, because that was the point, that if anybody dropped out, they'd be ranked worse. 4 of those patients ranked worse because their myasthenia gravis did worse, and 2 were in the placebo group and 2 were in the echo group. But the 3 other patients who dropped out because of serious adverse events, all of them in the echo group, all of them. So one was an infection, one was an intestinal perforation, and I think one was prostate cancer or something like that. And all of these 3 patients actually did well with their myasthenia gravis. So just because they dropped out, they were sort of put in there. So in terms of efficacy, when the worst rank ANCOVA was repeated with these 3 patients added in there, depending on their improvement, the worst rank ANCOVA was actually significant. So I'll stop there, and Gordon, I don't know if you have other comments.
Yeah, I can make a couple of brief comments. I totally agree with everything that Pushpa said. I can't speak to why they designed the trial this way, but I definitely think it's providing really useful information. And Pushpa already talked about the variability in response. I think the mechanism may actually be closer to plasma exchange, and we've got robust experience with plasma exchange. And I've personally exchanged people. I've had patients who are on chronic plasma exchange who've required twice a week exchanges, and you can do it indefinitely. So I think that there's not a lot of concern, at least on my part, that more frequent dosing is going to have untoward side effects. It's definitely true that with IVIG, patients vary a great deal in how they respond. And in fact, that variability is a way we reduce cost by stretching out the duration or lowering the dose of the agent. And so while the way they designed the trial creates a real challenge for us, and I think the company's struggling with this in terms of identifying what's the out of the gate dosing regimen, from a pragmatic perspective, it's a very comfortable space for experts who take care of myasthenia gravis, because I predict the way this will be dosed and used, as Pushpa said, is going to be very much like how we use IVIG.
Thank you both so much for your perspective. And then let me thank you, Dr. Gold, for being so patient. Do you want to go ahead with your question?
Sure. I have a couple of questions that are sort of related. One is, I'd like to get a sense of the age distribution of onset of myasthenia gravis. This is really to the clinical experts, and as well as it seems like there's this 2-year period where the disease kind of declares itself in one form or the other, and then from there on, it becomes a chronic disease at the same level. Were there to be an intervention earlier in those 2 years, is there any information about what the trajectory of the experience for the patients would be, or are there any suppositions about this, or is there any data?
Maybe I can go first this time, Pushpa. I'm just going to make sure, if you have a hard question, Pushpa will answer it first. I think that is a really insightful question. So myasthenia, I've seen myasthenia present in young children. I guess all age offender. Generally speaking, younger women. Oh, am I frozen?
You're okay.
You're okay now.
Okay. Yeah, I've got flaky internet. So I'd say younger women and older men for acetylcholine receptor antibody positive myasthenia, not the same demographic, and MuSK positive, but a really broad age range. The question about whether early treatment and ocular myasthenia reduces risk of generalization is a great one. And people have tried to study this, and I don't think we have an answer. And it's actually a hard question, because if you give steroids during ocular only myasthenia, you're going to get a treatment benefit, and understanding whether that's changing the natural history of what would have otherwise happened, or whether it's just a disease modifying treatment for that period of time, is tough to unravel. So I don't think anyone knows the answer to that. Maybe Pushpa knows the answer to that. I don't. I think it's a great question. But I'm not sure either one of these therapies would be likely to do that, because one is basically depleting the antibodies. It's probably not going to, I would think, result in, if you stopped it, long-term resolution of the problem. And then eculizumab is really targeting a downstream mechanism of injury at the neuromuscular junction. So my surmise would be that neither one of these are likely to change that natural history, but we don't have evidence whether steroids really do that or not. And Pushpa, you can correct me if I said anything wrong there.
That was really helpful. Thank you.
Gordon, no, I think that was the tough question that you took. Thank you. That's why I was hesitating, hoping you would jump in. But just a couple of other comments on age. Yeah, the typical teaching is, as Gordon said, younger women, older men in acetylcholine receptor antibody positive myasthenia. And we sort of divided into young onset, less than 50, and late onset myasthenia gravis, older than 50. And the populations tend to be a little different. MuSK myasthenia, the curve gets sort of shifted to the left. So everybody is younger, but there's a female predominance. However, it's interesting that and this was noted in this study, in these two studies as well, that I do think that there's been a shift in that age prevalence, and we are seeing more older women getting the disease now. And that has been noted in multiple trials recently. If we look at some of the randomized trials, it's surprisingly most patients, the disease, age at onset of the disease has been in their 60s, even in women. And you'll see here, both in Regain and in Adapt, that was sort of the mean age at onset. So there seems to be a shift, and we're actually looking at it in one of our observational studies that we're analyzing, because we saw the same kind of population shift. So I will say that in terms of this 2-year window, I think that 2-year window is more sort of a sense of when ocular generalizes, as Gordon was saying. I'm not quite sure that it applies to the disease itself, that it sort of becomes, the impression almost is that after 2 years, it becomes a burnt out phenomenon. And I don't think that's quite accurate. I think what happens really is that myasthenia is variable. I mean, we've all seen patients, I think, who will stay ocular for 2 years and then generalize out of the blue. I have a patient like that in the hospital just now. And it's also very variable on a day-to-day basis and with fluctuations. So I don't think it sort of stays burnt out. They can go after that and, sort of change from mild to moderate and even go into a crisis. So I think it's an extremely variable disease. So it's a little difficult to say that, yeah, once we reach the 2-year window, they sort of stay the same. So I would add that in there.
Yeah, I just want to emphasize that the variability is sort of a huge theme. I mean, you can't, there's no, it's really hard, no pun intended, to generalize about myasthenia. Anything can happen. It's highly unpredictable. And I'm sure our patient colleagues would agree with that.
Yeah, my sense is this is going to be a theme that comes up over and over today. Thank you so much. We are running a bit behind now.
Dr. Waspy, can I just answer
Sure. Yeah.
Megan's question?
Please.
So for eculizumab at 26 weeks, so the end of their primary trial, 21% had minimal symptoms versus 1.7% in the placebo group. For efgartigimod at 4 weeks, so when they had maximal benefit, it was 40% versus 11% in the placebo group. They didn't report that later on in the publication.
And I believe that this was minimal symptom expression, if I'm not mistaken.
It was, that's minimal symptom expression, yes.
Yeah, so it's a little different than the minimal manifestations that we sort of talk about. So the minimal symptom expression is a specific 0 to 1 MG-ADL score, whereas minimal manifestations tends to be an overall clinical descriptive impression, which none of these trials usually report. I don't think they reported them.
Thank you both. We really appreciate this kind of robust conversation. We are about 10 minutes behind, but I think we can catch up on the back end. So I'd like to introduce Dr. Dan Touchette to do the main presentation for the economic modeling.
All right, thank you. Next slide, please. And these are all of my graduate students and other students who helped with the development of the cost effectiveness model. None of us had conflicts of interest to disclose as described in the ICER policy. Next slide, please. All right, so the objective of this analysis was to evaluate the cost effectiveness of these two drugs, eculizumab and separately efgartigimod, compared with or added to conventional therapy, compared with conventional therapy alone. And there were two different populations for each of these. Again, for eculizumab, we evaluated those with refractory ACHR, AB positive GMG. And for efgartigimod, we chose to evaluate all of the patients who were enrolled in the ADAPT trial. That includes those who were refractory or labeled refractory according to the trial criteria, and those who were non-refractory. We just felt that this is the likely population, at least at this time, we thought this would be the likely population who would be treated, potentially be treated with efgartigimod. Next slide, please. We also conducted a number of scenario analyses in addition to the two base case analyses I just described. We did look at efgartigimod use in the refractory ACHR, AB positive GMG patients, those resembling the REGAIN trial. We compared with, the comparator was conventional therapy, and then we also tried to do an analysis comparing with efgartigimod plus conventional therapy. And then for another scenario, we looked at efgartigimod versus CT in just the ACHR AB positive GMG patients, which these are a broader group than those resembling the REGAIN trial. This is the group that was the primary analysis from the ADAPT trial. And then we also looked at IVIG and Rituximab. Next slide, please. Next slide. All right, so our brief methods, we have a Markov model was what we developed to analyze these. We specifically looked at whether patients achieved a 3-point or greater reduction in the QMG scale as those who would continue therapy. We also included MG-related hospitalizations, emergency room visits, and time-varying mortality in this model. The setting and perspective are typical for ICER analyses. The time horizon, we did use a shorter time horizon of 2 years for this. And the reason for that was beyond the time frame with which we were evaluating the effectiveness of these therapies. MG is typically not considered progressive, at least not on average. Although, as we've heard, certain patients may have fluctuations in their condition. These two treatments, the two treatments in the base case, the onset of these is relatively rapid. It's achieved within a few cycles. And so evaluating beyond 2 years, we were pretty certain that this would not have an effect on the cost effectiveness threshold or ratio. I mean, the ICER that we achieved. We did in another scenario analysis evaluated the 5-year time period, and this justified our assumption and using 2 years for all of the treatments that we evaluated. The cycle length of the model was 4 weeks, and the primary outcomes you can see here. We did cost per quality adjusted life year gained, cost per life year gained, cost per equal value of life year gained. We also included a couple of clinical outcomes, mean QMG throughout the time period evaluated, and time in the improved state. Next slide, please. Here is the model that we used to evaluate these two treatments. I'm going to go through an example with eculizumab alone. We use the same model for both treatments. All patients started in the model in the unimproved myasthenia gravis on the initial treatment, which in this case, for this example, is eculizumab. For those who had at least a 3-point improvement, we assumed that patients would continue on the treatment, and those patients moved to the improved MG and continued eculizumab. We estimated the actual benefit in terms of QMG and related that to utility overall for those patients. We did not assume a 3-point improvement. We actually estimated the actual improvement in the QMG score and the related utility for those patients. For those who did not benefit from treatment, we assumed that treatment would be discontinued. And so those patients moved to the unimproved MG, not receiving eculizumab, and remained there. Throughout any point in the model, patients could die from natural causes. We also included in the model, although it's not shown in the Markov states, we did include MG-related hospitalizations and MG-related emergency room visits. Those MG-related hospitalizations also included hospitalizations for crisis. Next slide, please. Here are the characteristics of the patients that we included. We show the target populations here for each of eculizumab and efgartigimod, are what I've already described. We did look at other target populations in scenario analyses. The mean starting age of patients in the model for male patients was 54 years of age, for females was 44 years of age, and we assumed 71% of the patients would be female. These estimates were taken from the ADAPT trial, for which we actually had values for gender-specific age. We did not have this information from the REGAIN trial, so we chose to use the data from the ADAPT trial. The REGAIN trial, patients were very similar. The 66% of the patients in that trial were female, and the average age of all patients was 47.2 years. So you can see that weighted value, the mean age was probably very similar to those in the ADAPT trial. Next slide, please. All right, here are the key model assumptions. Many of these assumptions were necessary to be able to run the model at all. Base case efgartigimod efficacy was assigned based on weekly dosing without discontinuation between treatment cycles. That's the data for which we had the strongest evidence available. So we assumed that patients would be continuing their treatment throughout the period. We did run a scenario analysis where we looked at every other month dosing. So on for 4 weeks, off for 4 weeks, and then starting the cycle over again for efgartigimod. And we did calculate the cost effectiveness of that regimen. The second assumption, patients who respond to treatment will remain in an improved MG state. And patients who did not respond would have that treatment discontinued and remain in an unimproved MG state. We do not have long-term, or at the time we did not have long-term data. We do not have long-term comparative data for these. So these were necessary assumptions. Change in utility is linearly associated with the change in QMG, regardless of baseline QMG score. Again, this was because the data that we had about utility and its association to QMG, we needed to have this assumption that there is a linear association between the two. And then there are no differences in mortality among living model states. We did not see any evidence of long-term mortality benefits for either of the treatments, although they may exist, they have not been demonstrated. And so we chose to not make an assumption that there would be mortality differences. Next slide, please. Here are the model inputs. Now, to get these inputs, we actually used a bootstrapping process. That bootstrapping process, with that bootstrapping process, we were able to estimate the proportion of patients who benefited from therapy. And we were also able to estimate the change, the mean QMG change in those subgroups, those who benefited and those who did not benefit from therapy. So having that information, that was information that was necessary for the model. We did actually get data from the ADAPT trial. And when we compared it, it was provided in confidence. We were not able to show that data. But when we compared it with our bootstrap values, the bootstrap values were very, very close to those, to the data that was provided to us for the ADAPT trial. So we felt confident in using our bootstrap values for these, for our model inputs. Given the similarity that we had with the ADAPT trial. We did not have similar estimates from the other trial for eculizumab. So these are the proportion of patients who benefited at week 4 and week 8 and beyond. So beyond week 8, we continued to, like I said, patients remained in that state, and the same proportion of patients remained in the improved state. So these are the estimates here on this page. So the next slide, please. Here was the probability of hospitalizations and emergency room visits per 4-week period, which is the cycle, the model cycle length. So you can see 2 to 4% were hospitalized, depending on whether they had improved MG or unimproved MG. And for emergency visits, 3 to 4% of patients, 3% in improved, 4% in unimproved, had emergency room visits each cycle. Next slide, please. Here we have the costs or estimated cost of the drug. So for eculizumab, the annual net price was $653,000 per year. For efgartigimod, we estimated a price based on some information we had around the likely pricing for the drug, and that price was used throughout the model or throughout this presentation. That the annual net price is $418,000. Next slide, please. The drug administration cost per injection for eculizumab, we obtained a value of about $230 per infusion. We assumed a similar cost for infusing efgartigimod. We do not know what the actual price will be for infusions of efgartigimod. It is important to realize that with efgartigimod, there are 4 weekly infusions, and then depending on the dosing, redosing frequency, that can actually amount to a substantial cost of about $1,000 per cycle. So those infusion costs were higher because of the frequency with which efgartigimod is infused. Next slide, please. Here were the costs per hospitalization. These costs did include crises. It was all lumped into hospitalizations, and this is from a publication in 2017, so fairly up to date. And then for emergency room visits, it was very difficult to find any value for the cost of an emergency visit for myasthenia gravis. We did end up using some estimates from the HCUP project, and the estimates shown here at 563. We did believe that was probably a lowball estimate. And so in sensitivity analyses, we varied this value considerably, all the way up to 4 times this value, to see what impact a higher cost would have on the results. I'll show you those later. Next slide, please. Here are the utilities that we used. These utilities came from a data set that we received from Dr. Carolina Barnett. We actually did a regression model to estimate the relationship between QMG and the utilities, and they're shown here. So at baseline, patients had a mean utility of 0.47, which is an incredibly low starting utility value. This is similar to utilities that are seen with primary progressive and secondary progressive multiple sclerosis prior to treatment, and in patients with severe depression prior to receiving effective treatment. So this is, these patients had a very poor quality of life. For each improvement in 1-point improvement in QMG score, that led to an increase in the utility of 0.03. So someone having a 10-point improvement would end up with a utility of 0.77 with that improvement, which is closer to population norms. Disutility of hospitalizations and emergency room visits, we also applied those for the time that patients would be expected to be in the hospital. The disutility associated with those was 0.22, and that was applied for 1 week for hospitalizations and 1 day for emergency room visits. Next slide, please. Next slide. Here are the results. Again, I want to point out that for efgartigimod, these are using the placeholder prices. So that's the cost that we estimated here. For eculizumab, we see the drug costs, total drug costs are approximately $760,000 a year. Or sorry, $760,000 for the 2-year period. For efgartigimod, it's $595,000 for the 2-year period. And you can see the total cost in the second column for treatment and treatment with conventional therapy. One thing to point out here is that for conventional therapy, we assumed that the underlying conventional therapy would remain the same in both groups. So we did not apply a cost for conventional therapy because it would have been subtracted out as when we compared the two groups. There's a substantial improvement for both treatments in terms of QALYs and EVLYGs. We did not see any change in life years because we again had an assumption that the treatments would not improve mortality. And the time in improved state is shown here. So a substantial amount of time in an improved state over the 2-year period for those patients on eculizumab and efgartigimod. Next slide, please. Here are the base case incremental cost effectiveness results. We see that eculizumab, using this model, the estimated cost effectiveness is $5.2 million per QALY gained. For efgartigimod, it was roughly a little over $2 million per QALY gained. The cost per year in an improved state is also shown here. So $1.8 million per year in an improved health state for eculizumab, and about $900,000 per year in an improved state for efgartigimod. Next slide, please. Here are the results of a number of different scenario analyses that I presented earlier on. So for the 2 different efgartigimod groups, we see really not much difference in the cost effectiveness in these 2 scenarios. So it doesn't really matter which population we look at. There are differences in the cost effectiveness, but the cost effectiveness still remains close to $2 million per QALY gained. For IVIG, we saw a pretty significant cost per QALY gained of about $1.5 million. And for rituximab, it's closer to what are viewed as acceptable norms, or closer to the threshold of $358,000 per QALY gained, but still substantially above the threshold. Next slide, please. Here are the one-way sensitivity analyses. We did look at all of the model inputs. Many are reported here. And some of the inputs did have an impact on the overall estimates because of the uncertainty associated with those parameters. I just wanted to point out that right at the bottom of all of this is the cost per ED visit, even using a very high or a much higher cost of $2,250 per emergency room visit. It has a very minimal impact, and that's because of the proportion of patients who actually have ED visits and the relatively low cost of an ED visit relative to perhaps the cost of the therapies and other costs that were included. Next slide, please. Here are the top 4. Again, this is looking at eculizumab plus conventional therapy versus conventional therapy alone. Here are the top 4 inputs. And you can see that while there's substantial variability in the overall incremental cost effectiveness ratios, the ratios do not drop below $3.8 million, regardless of which parameter was univariately altered in this. Next slide, please. We see a very similar pattern with efgartigimod, obviously, because the base case analysis, we had a much lower incremental cost effectiveness ratio of just over 2.1 million per QALY gained, or just under 2.1 million per QALY gained. Next slide, please. What we see here is that at the lowest end, again, univariately adjusting these in one-way sensitivity analyses, we see that the ICER does not drop below $1.7 million per QALY gained. Next slide, please. In probabilistic sensitivity analyses, we did not see any of the runs in the analysis drop below a cost effectiveness threshold of 200,000 per QALY gained. So that means that even varying all of the parameters at the same time, we saw that these treatments did not achieve the threshold price below at least 200,000 per QALY gained. Next slide, please. There are a number of limitations to consider for our analysis. The first is that efgartigimod dosing frequency is not known, and the effectiveness is not known at these different dosing frequencies. We did receive some data from the long-term open label trial from ADAPT on efgartigimod, suggesting perhaps a lesser frequency might be possible to maintain patients, but we do not know, what the impact is on QMG with these longer timeframes, or what the impact would be on utility with these longer timeframes. We just know that the redosing was at a frequency to try and achieve a QMG change above 3, or a reduction above 3 points on the QMG scale. But obviously that would result in fluctuations in patient symptoms. Sample sizes resulted in greater uncertainty, or the small sample size resulted in a high uncertainty of the treatment effectiveness. This was even more pronounced in subgroup analyses where we had a smaller number of patients. The bootstrapping was necessary in order to get the key inputs to be able to estimate the actual changes in QMG. Of course, with the bootstrapping process, these results may not precisely replicate the study's results. As I said, the results were actually quite close to the estimates that we received. They were within 5% overall of the estimates that we received from the ADAPT trial. So we felt pretty confident with the bootstrapping. There were a lack of controlled results in long-term studies. So we did receive some information about open label information from open label studies, and also post-marketing in the case of eculizumab, but none of these estimates really gave us the ability to assess the actual impact of these treatments in those long-term studies. Most notably was eculizumab has some post-marketing data on steroid-sparing effect, and that steroid-sparing effect was actually not different than what we observed in the placebo arms of the IVIG trials and of the Rituximab trial. And so that we chose not to incorporate a steroid-sparing effect because in our opinion, it was not well demonstrated that there truly is a steroid-sparing effect with eculizumab. And then last limitation listed here is that data regarding the impact of treatment on productivity, caregiver burden, and other societal costs or benefits is lacking. We could not find that data in the published literature. That's an important consideration, possibly one of the major considerations when evaluating the model, because these benefits, we don't know what the benefits of treatment are on these societal societal inputs, productivity, caregiver burden. We don't know the effect of treatments, but if there is an effective treatment on these, this could have an important effect on patients' lives. Next slide, please. We did receive a number of comments which we addressed. The first was that the 2-year time horizon did not sufficiently capture long-term outcomes, especially specifically the long-term steroid use on patient health was not evaluated in the model. I think I addressed that already. We do not know what the effects of treatments are on steroid sparing, whether they truly are steroid sparing and to what degree they are. So being able to incorporate this in the model is very difficult. And so the 2-year time horizon, given what we were able to incorporate in the model, we felt was a sufficient amount of time to evaluate these outcomes. The mean median dosing frequency of efgartigimod in the open label trial was longer than what was modeled. And that is true. However, we were not able to use a different dosing frequency beyond 8 weeks because we did not have comparative data on what impact that longer dosing frequency actually had on QMG values and subsequently on utility. There were utilities that were obtained in the ADAPT trial. We did receive that data again in confidence. We did include it in an evaluation in one of our scenario analyses, and we saw that these utilities had minimal impact overall on the cost effectiveness as well. In some cases, increasing the cost effectiveness of efgartigimod, and in other cases, decreasing it.
Dr. Duchette, I'm so sorry to interrupt. Do you mind just moving ahead to the conclusions? I just want to make sure that we have enough time. Yeah, sorry. Thank you so much.
Not a problem. Next slide, please. All right. So here is the cost effectiveness. The conclusions are the cost effectiveness of eculizumab at its current price is well beyond typical thresholds. The cost effectiveness of efgartigimod obviously will depend upon its price. If priced at our placeholder price, it is also well beyond typical thresholds. And IVIG and rituximab results were not discussed much, but those were also above commonly used thresholds. And so given all of this, access to effective treatments for myasthenia gravis in patients not receiving sufficient benefit or experiencing intolerable adverse events from conventional treatments may be limited because of their prices. And that's an important concern. Next slide, please. That's all. So I'll take questions now.
Thank you so much, and congrats to you and the whole economic team. Is really rigorous and detailed analysis. We're very appreciative. We are planning to move to public comments at 11:40. I think we can go a few minutes over just to make sure that we have any questions from the CEPAC. Please just either raise your hand or you can even just turn on the microphone. Dr. Kogut, I can see your hand up.
Great. Thanks for that terrific presentation, and kudos on the modeling of this challenging question. I was just kind of a bigger picture question, thinking about the QALYs gained incrementally for eculizumab. And could you maybe help us understand of how that compares to other analyses that you've done? Is the model sort of capturing enough benefit in your mind, given that this drug was rated as a B+ product by the evidence review team?
Sure. So, I mean, I guess the key factors that are present here are the proportion of patients who gain benefit from the therapy and the actual QALY gains in those patients. So, the proportion of patients who benefited from treatment, if I go back, is around 50 to 60%, 60% for eculizumab and 70% for efgartigimod. So a substantial proportion of patients gain benefit. But there are some who do not, who didn't gain sufficient benefit. And then the QALY gains were actually quite significant. I think the mean QMG was, for the two treatments, was mean reduction in QMG was somewhere between 7 and 10 points on average. Which is enough to bring that utility up with the equation that we used from 0.47, which is horrendous, to 0.77, which is much more aligned with the general population. So significant QALY gains in those individuals who benefit from treatment. Great. I hope that breakdown helps. Is there something else you wanted me to answer?
Well, it's related to the suggested price of the product that would yield a cost per QALY of $150K, and I think that was like $19,500. And I don't know. To me, it just seems like that price is pretty low to inspire innovation in this space, and it makes me wonder if perhaps the model isn't capturing enough benefit.
Yeah, I mean, the model is capturing the benefit as was observed in the clinical trials. again, and substantial gains in the utility. I think the issue is that these are chronic treatments, and so it's. I think at a cost of 100 or so thousand per year, that's pretty similar to what we see from many other chronic treatments for this type of a benefit. At 800,000 or 750,000 a year, or 450,000 a year for that matter, those are extremely high prices to pay, even for such significant benefits.
Thanks a bunch. Perfect.
Thank you to both of you. And I'd like to call on Dr. Lavelle.
Hi, thank you. I had a couple of questions related to the assumptions in the model, and I just wanted to bring them up in case you had done any sensitivity analyses around these that you didn't present. But the first one, I'll just say both of them together and then let you respond. But the first one is that you assume that patients who were responding to treatment continued to respond. That seemed like a big assumption considering the amount of follow-up data that there were in the trial. So just wondering if you've done any sensitivity analyses around that. I guess I'll stop there and let you answer that one.
Yeah, for that specific assumption, we did not. We had evidence from the open label trial that patients who benefited from treatment and continued to receive treatment, there were very few discontinuations. And over time, the company showed us that there was a pretty consistent average response among all participants over that time period.
Okay.
Yeah, and so that was partly underlying the assumption.
Okay, and then another quick question is that you assume this linear relationship between the QMG score and utility, and that is pretty unlikely just given utility theory. And I just wonder if I understand the reason for needing that assumption given the structure of the model, but whether you looked to see whether that assumption held and, what the implications would be if, given other relationships that you may have seen when you were constructing that model.
Yeah, another great question. We did, do some very simplistic analyses to look at whether that relationship was true, and it certainly was true for the vast majority within certain ranges of QMG and utility values. That may not necessarily be the case at the extremes as well. That's part of the reason why we chose to use QMG as well, because the relationship broke down a little. The linear relationship broke down a little more with the MG-ADL scores, it was certainly for patients with extreme values. At the edges, those with really good QMG scores and those with really poor QMG scores, which were a fairly small proportion of patients. There's a possibility that that linear relationship did break down, yes.
Okay, that's helpful, thank you.
All right, thanks to both of you. I hope I didn't rush everyone too much. I think we're almost back on time. So thank you all so much for helping. We are now going to move to public comments and discussions, and we have pre-registered